Evening. We are going to pick up where we left off last Thursday. We're going to finish talking about how carbon dioxide gets transported around the system and get back to the lungs. We'll talk about breathing. And we're going to talk about some different conditions tonight. And then I have a review to go through once we get through these 50 some slides left of this PowerPoint. So carbon dioxide. Carbon dioxide technically has three ways that it gets transported in our system. Some of it gets dissolved in plasma, not a lot. We have some that is bound to hemoglobin, which it can only bind to hemoglobin once oxygen has been released from that hemoglobin. So that is what is referred to as carbaminohemoglobin, because hemoglobin is technically an amino acid. It's a chain of amino acids, and a chain of amino acids are proteins. So that's where the amino comes from, and it's hemoglobin. The most carbon dioxide is transported as bicarbonate ions. So as carbon dioxide diffuses into the capillaries, what is going to happen is it's going to actually react with water as long as we have an enzyme called carbonic anhydrase. So carbon dioxide and water and this carbonic anhydrase are going to come together and form carbonic acid. Then once we have carbonic acid, it will dissociate into a hydrogen ion and a bicarbonate ion. So after we make that bicarbonate ion, it's going to go from the red blood cell where this reaction occurs, and it's going to kind of diffuse back out into the plasma where it travels through the blood vessels or the veins back to the heart, which then pumps it back to the lungs. There's a whole chemical reaction that is happening, which is called a chloride shift. So is carbonic acid is being pushed out of the cell to go into the blood plasma. Chloride ions are moving from the blood plasma into the red blood cells. So they're exchanging one negative for another negative ion because they're trying to keep an electrical balance between that blood plasma and that red blood cell. That is what is known as that chloride shift. So here is this reaction occurring. We're getting carbon dioxide coming out of the tissues. It is going from that interstitial fluid into the capillaries, which will then go into the red blood cell. Once it's in that red blood cell, it's going to react with water, and that carbonic anhydrase is going to make carbonic acid, which will then dissociate into bicarbonate and hydrogen. So you can see that bicarbonate leaves the red blood cell as it now is being transported in the plasma, while that chloride is coming back in or going into that red blood cell, which is causing a chloride shift. So once our red blood cells get into the lungs, we need to get rid of that carbon dioxide and we need to pick up oxygen. So what just happened when the blood and the carbon dioxide was out in the interstitial tissues is now going to come back to reverse that process. So that bicarbonate is going to go back to that red blood cell. When the bicarbonate ion goes in, chlorine or the chloride goes out because they got to keep that chemical balance. That bicarbonate is going to bind with hydrogen again, which is going to form carbonic acid. Then that carbonic anhydrase is going to take that carbonic acid and it's going to make it into carbon dioxide and water. Carbon dioxide will then diffuse out of the blood cell, out of the capillary, and into that alveoli. So we went through the first part of that process. Now we're going to go through the next part. So we're coming back out. So we have that bicarbonate ion that's coming back into the red blood cell. Going to attach to this hydrogen ion. It'll then make that carbonic acid. It's going to react with that enzyme carbonic anhydrase, and it'll make water and carbon dioxide. That carbon dioxide then leaves the blood cell, leaves the plasma, leaves that capillary, and goes right into the alveoli. So we have what is called a Haldane effect. This Haldane effect has to do with the amount of carbon dioxide and oxygen. It's the exchange of carbon dioxide or oxygen for carbon dioxide. That is all this pretty much says is we can't put a new carbon dioxide into our blood to be transported unless we get rid of an oxygen. If we add an oxygen, we have to get rid of the carbon dioxide. So you can't add more carbon dioxide without getting rid of oxygen. You can't add oxygen without getting rid of carbon dioxide. That's what the Haldane effect means. So we have our whole reaction. We're getting rid of carbon dioxide and we're adding oxygen to our red blood cell again. So pH also plays a role in gas exchange of carbon dioxide and oxygen. But we do have what is called a carbonic acid bicarbonate buffer system because it tries to help keep our oxygen, carbon dioxide levels somewhat regulated, even if the pH in our blood changes. So if we get too much hydrogen, hydrogen refers to pH. So if we have too much hydrogen, we're going to make carbonic acid. which will make carbon dioxide and water. But if we don't have enough hydrogen, if our hydrogen drops, we're going to take that carbonic acid and get rid of that hydrogen. So now we have out of that carbonic acid, so now we have hydrogen ions. We try to keep our levels balanced. So, of course, just like anywhere else in the body, our blood will do this with carbon dioxide, oxygen, and their hydrogen atoms. Bicarbonate ions are more alkalinic. So they're part of that buffer system that helps to try to keep the pH level in our blood level. So what happens if you take some slow, shallow breaths? It actually causes more carbon dioxide in the blood. We have more carbon dioxide, our pH drops. What if you're breathing really fast and shallow? Or sorry, rapid deep breathing. I read that wrong. So this is slow, shallow breathing, increases carbon dioxide. Rapid deep breathing decreases carbon dioxide. If we have a decrease in carbon dioxide, we're going to raise our pH in our blood. So how we breathe actually can change the pH levels in our blood. It controls that acid-base balance just by how deep of breaths you take or how fast or slow of breaths you take. They all play a role in how everything else in your body functions. Hypoxia. Hypoxia refers to not getting enough oxygen into our system. If you don't have enough oxygen in your system, it can result in cyanosis, which means your skin turns blue. Or if you have darker skin, you can see the color changes in the fingernail beds and the gums in people's mouths. You can see the color changes that you would see on a very pale, like a pale person's skin. You could still see it in people's nail beds and their gums in their mouth on darker skins. We have anemic hypoxia. Most of the time, people with anemia have a lower count of red blood cells, but there's so many different kinds of anemia. It could also have to do with hemoglobin. If you don't have enough hemoglobin, there's not enough place to carry oxygen. Just like if you don't have enough red blood cells, there's not a place to carry oxygen. We have ischemic hypoxia. Ischemic means there's not blood getting to a certain area. So that skin is or areas can turn blue. Usually starts white. If there's blood circulation cut off to that area, that skin color could turn more white or very pale. And then if it stays, the circulation stays black long enough, it does start to turn blue. Histotonic hypoxia. So we can't use the oxygen that we have in our system. Something like cyanide. Cyanide blocks some of the processes and we're unable to use oxygen that we take into our system. Hypoxemic hypoxia. They're not breathing correctly. There's something abnormal about their breathing. So it's some kind of pulmonary disease. So they're not getting enough oxygen in their system. Carbon monoxide. Hemoglobin will bind to carbon dioxide a lot easier, faster than it does with oxygen. It has a higher affinity for binding. So if somebody gets carbon monoxide into their system, it binds to that hemoglobin. So your hemoglobin can no longer pick up oxygen. And if you can't pick up oxygen and take it to your tissues, it can cause all kinds of problems. Like your brain uses a lot of oxygen. So if you're not getting enough oxygen, you get headaches. You can become very flushed. You can get really dizzy. You can pass out. So carbon monoxide poisoning, that's why it's not required to have carbon monoxide detectors in homes, just because it's known as a silent killer, because it can bind to your hemoglobin and you're no longer getting oxygen to your body. So our brain, just like everything else in the body, our brain is going to control our the rhythm of our breathing. Different parts control breathing in versus different parts will actually control breathing out at some points. So the main area for breathing, we have the medulla and the pons are the two places that control breathing. In the medulla, we have the ventral respiratory group and the dorsal respiratory group. Dorsal respiratory group used to be called the inspiratory area, while the ventral respiratory group used to be called that expiratory area. So with the names that they used to be called, it tells you pretty well what they do. But that ventral respiratory group, they control the rhythm of your breathing. So there's some new studies that are out that if you do some kind of forced expiration, it can separate the groups of neurons that are used in passive respiration. So we do separate neurons for forced expiration versus passive expiration. They do lots of really cool studies sometimes. So that ventral respiratory group, they go from the spinal cord to that pons medulla junction to control breathing. Normal respiratory rate is eupenia. U at the beginning talks about something that's normal. Penia refers specifically to breathing or that respiratory rate. And as I said last week, normal breath, we normally take 12 to 15 breaths per minute, something we cannot really control. I mean, you can control it, but you can't really test your own rate because then you're too conscious of what you're doing. And then you usually get some either more or a whole lot less. But our diaphragm and those external intercostal muscles are innervated by the phrenic nerve. I had a teacher teach me in school for the phrenic nerve when I needed to know because the phrenic nerve comes out of your cervical spine. See, I had to one of my teachers started teaching me that's C 3, 4, 5 keeps you alive. Because those are the three roots that the phrenic nerve comes out of, and it goes down to that diaphragm. So if that phrenic nerve isn't going to that diaphragm, you can't use your diaphragm to breathe. And we always, even though we talked last week about how different pressures change our breathing, we still have neurons that are going to inhibit each other when they talk to each other. They're going to be like, that are going to say, okay, it's time to inhale. So those expiratory neurons get inhibited and then switch. Those expiratory neurons are going to inhibit the inspiratory neurons when it's time to breathe out. So they kind of they inhibit each other so that the whole breathing process can actually occur. This dorsal respiratory group. These come out near cranial nerve 10. So they kind of use stretch receptors, they're going to use chemoreceptors, and they're going to send information to the ventral respiratory group. So again, these neurons communicate with each other. That's about all we know about the dorsal respiratory group, though. There's still they're always doing research, learning new things. So there's still not a lot known about this dorsal respiratory group. What about these pontine respiratory centers? The pontine respiratory centers are actually they may influence, they may modify that activity of the ventral respiratory group. Because we want to breathe, when we breathe in, we want to just naturally breathe out. We want it to be a smooth process of breathing in and breathing out. Our pontine respiratory center makes sure that happens. We want to make sure we get that rhythmic breathing in and breathing out, and it's smooth. It's not kind of jerky or all over the place. Because they're actually the pontine respiratory centers. They help with your voice, your speech, sleep, and when you exercise. Because when you exercise, you're usually breathing heavier than at rest. So that pontine respiratory center kind of helps take over and control a lot of that. If something were to happen to that pontine respiratory center, we would get something that's called apneustic breathing. That person takes prolonged inspirations. So they're taking long breaths in and a normal breath out. So this picture from your book shows the different areas in the brain and what they do. Because that pontine, it interacts with that medullary because we want smooth breathing. The ventral, rhythmic generators whose output drives respiration. That dorsal, they're going to integrate peripheral sensory in. And then that phrenic nerve I said C3, C4, C5 innervates that diaphragm, or that C3, 4, 5 keeps you alive. We still don't really know the actual origin of breathing rhythm that causes us to breathe in and breathe out. They've got different hypotheses, but nothing has actually been proven yet. One of the hypotheses that your book talks about is pacemaker neurons that are in that ventral respiratory group, and they help to control that rhythmicity of breathing, that breathing in and breathing out. There's also, this one's more widely accepted, is we use a reciprocal inhibition. So there's two sets of pacemaker neurons, and they generate that rhythm of what allows us to breathe in versus breathing out. So how deep do we take breaths? So if we take a really deep breath, those respiratory centers are going to stimulate those respiratory muscles to allow you to take in a deeper breath. The more stimulation, the deeper the inspiration. If you remember how nerves work, they're sending those action potentials down to that nerve terminal, which is the end of that nerve that communicates with whatever it's communicating with. And in this place, it could be our respiratory muscles. And just like any other muscles in our body, the more signals that are sent to that specific muscle, the more that muscle is going to contract. So if these neurons are rapid firing information to, say, your diaphragm, it's going to cause that diaphragm to contract maximally, which is going to cause a deeper inspiration. So how long we're breathing in or out, it's how long that center is active. That dorsal or ventral respiratory group. And of course, they're going to be modified depending on what you're doing. Sitting in a chair versus running across the street or just walking down the block. They're going to be modified just based off of what activities you are doing. Even sleeping, they're going to be modified differently because you breathe differently when you're sleeping versus when you're sitting on the couch watching TV. Of course, just like anything else in the body, chemical factors play a role in your breathing. Your higher brain centers, pulmonary irritant reflexes, and inflation reflexes all play a role in your breathing. So let's look at how those work. So chemicals, we've already talked about a little bit with oxygen and carbon dioxide. Those are the main chemicals, but also pH, so hydrogen ions also play a role. So if our pressure of carbon dioxide versus our pressure of oxygen is going to depend on how deep of a breath you take. If you need are desperate for oxygen, it's going to cause you to take deeper breaths. Versus if you have a lot of carbon dioxide, it's going to cause you to make sure you take good exhalations out to get rid of that carbon dioxide. So just like when you learned about the nervous system, that's central chemoreceptors. Central means it has something to do with either the brain, the brain stem, or the spinal cord. Well, since the breathing areas in the brain are technically in that brain stem, there's also going to be chemical or central chemoreceptors. Chemoreceptors deal with chemicals. So those receptors in the brain that deal with the chemicals that help you breathe, oxygen and carbon dioxide. We have peripheral chemoreceptors. Peripheral, it's outside that central nervous system. So in your aortic arch, your carotid arteries, they have chemoreceptors in those arteries that monitor your oxygen and carbon dioxide levels. They are all going to play into what is occurring. What about those pressures of carbon dioxide? We get too much carbon dioxide in our blood, hypercapnemia. Our carbon dioxide is actually going to accumulate in the brain. When carbon dioxide joins with water, just like we talked about when carbon dioxide was carried in the blood not too long ago, it turns into that carbonic acid. That carbonic acid dissociates into hydrogen and that bicarbonate ion. And that's what causes our pH to drop. What if we have an increase in hydrogen ions? Well, your brainstem is going to reverse that process where it's going to take the bicarbonate ion, add it onto that bicarbonate, and make carbonic acid. Carbonic acid dissociates into carbon dioxide and water. That'll help with changing the pH. We can also change our depth and our rate of breathing to lower that carbon dioxide in the blood. It's another way to change the pH levels. Breathe deeper, get more oxygen in, get more carbon dioxide out. What if our carbon dioxide levels get too low? That's when we start breathing slow and shallow. We don't need a lot of oxygen. Our system still needs to have some kind of carbon dioxide in it. So apnea, that's where breathing stops because carbon dioxide levels drop too low. Sometimes, I mean, I've seen more than just swimmers do it, but swimmers do it because they have to hold their breath longer being underwater. They hyperventilate before they start a race. So they get a lot of oxygen into their system and it allows them to hold their breath longer so they can swim faster without needing to take a breath. So it's one thing that athletes like to do to try to improve performance. So here's just a chart from your book that shows what happens if we get too much, we have an increased carbon dioxide, what our system does to get us back to normal. Hyperventilation. You take deep breaths at a higher rate. We're trying to remove carbon dioxide from the system. If you've ever seen somebody have an anxiety attack, sometimes an anxiety attack can lead to this hyperventilation. But as we remove too much hyperventilating, you start to remove too much carbon dioxide from the blood. Can cause cerebral vasoconstriction, which means those blood vessels in the brain are getting smaller. Cerebral ischemia can get really dizzy and faint. Could get tingling, involuntary muscle spasms. That's where they tell people to breathe into a paper bag. If you ever see anybody hyperventilating, a paper bag is the source because it's allowing them to breathe back in the carbon dioxide that they are breathing out a lot of. And that helps to level out that carbon dioxide in their blood, and eventually they will start to turn back into normal breathing from there. So as we said, there's receptors in the aortic arch and those carotid arteries, because we need to watch those oxygen levels. We need to make sure we have the right amount of oxygen being pumped out to the rest of our body. But if we have a decline in oxygen, it's not a huge deal because we always have oxygen bound to hemoglobin. If we have a substantial drop, though, that's what's going to cause you to increase breathing. More breathing, more oxygen comes in. So when those chemoreceptors get activated because of a low oxygen in the blood, it causes the respiratory centers to increase that ventilation. Get more breathing in, let's get more oxygen going. That is the role of these receptors in these blood vessels. So this shows where those receptors are located. You see these aortic bodies. They're here in purple. You also see them at the carotid body, where that carotid artery turns into an internal and external carotid artery. Those are monitoring the oxygen levels in our blood. We've talked about pH, that amount of hydrogen ions that affects the pH of our system. Of course, that's going to change your respiratory rate. The thing is our respiratory rate can change even if carbon dioxide and oxygen are normal. Again, we have those receptors, as aortic bodies and those carotid bodies that monitor the oxygen level in our blood. If we have a decreased pH, we may have more carbon dioxide retention. We have an accumulation of lactic acid. Lactic acid is created during exercise through glycolysis, the anaerobic glycolysis, we are creating this lactic acid because glucose is being used to make ATP, but we only get 2 ATP, then we technically get 2 pyruvic acids from glycolysis. Those pyruvic acids get converted to lactic acid, which is supposed to diffuse out of the muscle cells and into the bloodstream. So as we get more and more lactic acid into our bloodstream when we're exercising, that causes a drop in our pH. We can also have excessive ketone bodies. Somebody who burns fat for energy, they're going to have ketone bodies in their blood. Our respiratory system works to try to fix a decreasing pH, also a raise in pH, because they increase the respiratory rate and their depth of breathing. Do we need more oxygen? Do we need less oxygen? How is that going to fix our pH in our blood and our system? Our body's constantly monitoring that 24/7. So this slide just kind of summarizes. We have raising carbon dioxide levels. That's going to cause you to breathe deeper. Our blood pressure, our oxygen, it decreasing levels necessarily won't change it, but a severe drop in oxygen levels will change our respiratory rate. Like when it falls below 60 millimeters of mercury. It's a stimulus for respiration. pH, because of carbon dioxide. Could be retention or metabolic factors. Lactic acid, ketone bodies. They're going to act on those chemoreceptors and try to bring more oxygen in. How about our brain centers? We have hypothalamic and cortical centers. Those are higher up than that midbrain. So the hypothalamic controls actually works through that limbic system. That limbic system can change the rate and how deep we are breathing. So our limbic system usually deals with emotions. So when you get mad, you're pissed off at something, tend to hold your breath. Or when you're in a lot of pain, depending on where the pain, it can either cause shallow breathing, gasping for air. That's all controlled by that limbic system in your brain. That limbic system will also respond to body temperature changes. What about cortical controls? Well, that motor cortex. What if you decide to hold your breath? What's going to cause you to start breathing again? That brainstem. That brainstem is what causes you to start breathing again when you start holding your breath. Because we need to get oxygen into our system. So that's why you can only hold your breath for so long. I know people train to try to hold their breath longer, but technically you can really only hold your breath for so long before that midbrain or that brainstem actually comes in and says, hey, stop it, let's breathe. Pulmonary pulmonary irritants. If you're in a place of high dust, like living in the desert, there's going to be a lot more dust around. There's a lot of places on the other side of the world that they just have a lot more dust and things in the air. That's going to influence breathing. If you've got mucus in your respiratory system or noxious fumes, our vagal nerve or vagus nerve is going to communicate with those respiratory centers to try to get that dust out of the system, try to cough to get that mucus out, or try to get that fumes, those noxious fumes, out of your nose. I said some of those irritants can cause you to cough or sneeze. Try to get rid of that mucus. You breathe in some of that dust and it starts to kind of tickle as it goes down. It causes you to cough or sneeze. Same as some fumes. If you've ever been in some place where you've smelled something that's just horrendous, it does cause you to start coughing a little bit to try to get that fume out of your system. So we have a reflex that is called the Herring-Brewer reflex or inflation reflex. And it has to do with stretch receptors. Just like in your skeletal muscles, your smooth muscle, your lungs, and that pleura has stretch receptors. That when the lungs start to inflate with air, everything starts to stretch. And when everything starts to stretch, those lungs, that pleura, which causes your rib cage to expand, all of that is going to start sending inhibitory signals so we can breathe out. Say, okay, we've breathed in, now it's time to breathe out. It's thought that this Herring-Brewer reflex or inflation reflex is kind of a protective response to make sure that when we breathe in, we also breathe out. It's to kind of keep breathing regulatory. It's that mechanism to keep you breathing in and breathing out. So here's all the different things that can cause us to breathe in or breathe out, like stretching of the lungs, irritant receptors, chemoreceptors, central chemoreceptors. We have receptors in our muscles and our joints. Because if you start running, it's going to change your breathing rate. If you start walking fast, it's going to change your breathing rate. All of that causes different receptors to trigger you to breathe differently. Respiratory adjustments. So as I've been talking about, exercise. Our breathing rate, depending on what you're doing during exercise, how intense you are working out during exercise, your breathing rate needs to change. Hyperpnea and hyper, it's above normal. Pnea has to do with breathing. So hyperpnea means you're breathing more breaths per minute. So technically it's anything over 16. I remember right, it was like anything over 16 breaths per minute is considered hyperpnea. So if you start running to chase something or just run because you like running. I know different people don't like to run unless they're forced to. So if somebody's chasing you, that would force you to run. Just to get an idea of what I'm talking about. So your breathing rate changes really fast at first, and then it's gonna steady out depending on how long you keep running for. Or so your body has a way to get enough oxygen in to get you going with what you're doing, and then it gets your breathing rate steady so you can continue to do what you're doing and get whatever oxygen in your body needs to continue whatever exercise. When you stop exercising, depending if you just sprinted across the street, I mean, you will slow down your breathing, but you're going to continue breathing heavy for a short time, but it's going to gradually slow down once the oxygen levels get replenished everywhere throughout the body. Because you're not just replenishing the oxygen levels in your blood. Your muscles store oxygen. So those oxygen levels have to get restored before your breathing comes back to normal as well. It's kind of known as oxygen debt. And that all oxygen levels have to be restored back to normal before your breathing rate is completely back to normal. But your body is really good at maintaining carbon dioxide, oxygen, and pH during exercise. They stay pretty consistent the entire time, which is very helpful with being able to breathe and being able to exercise and do what you want to do, have enough oxygen in your system. So it causes you to start breathing really quick, like increase ventilation quickly once you start exercising. Some people like to say that they like to get up and run in the first thing in the morning before their body knows what they're doing. I've been one to say that sometimes, and I have plenty of friends that say that. But your body still knows it's coming, even though, because you still have to get dressed and get out the door, get on the treadmill wherever you're going to run or something. So your body has time to anticipate that it's going to happen. So your body does know it's coming, even though you say it doesn't. Of course, we have that cortical motor activation because that's what's going to tell your muscles to start moving when you start exercising. We have those respiratory centers. Those are going to tell you to start breathing heavier. We get more excitatory impulses to generate more breathing. It starts as a gradual increase, but then we hit a plateau. That plateau means we're just not going to go any higher. And that plateau is because of we're getting that carbon dioxide delivered out to the lungs. Oh, as I mentioned, that ventilation is going to go down after you exercise because it'll gradually decline because we're trying to get rid of that carbon dioxide. We're trying to get oxygen stores back to normal. And as I've mentioned before, at anaerobic respiration, which is glycolysis. Glycolysis forms that lactic acid. Technically, our muscles cannot use lactic acid. They have to convert it back to pyruvic acid, and then they can put the pyruvic acid into the aerobic respiration, which is the Krebs cycle and the electron transport chain to make ATP. But your heart uses lactic acid for energy to make ATP, actually. But we're missing oxygen. It's not because of breathing. It could be from your heart not pumping enough blood out. Maybe your muscles aren't taking up oxygen out of the blood as efficiently as they should. This all kind of affects your oxygen levels throughout the system. What about high altitude? If anybody's ever tried to do anything at very high altitudes, you notice that it's a lot harder to breathe. So if you were to hop on a plane, go to Colorado, Utah, any of the Oregon, even California, Washington, anywhere that's got over 8,000 feet of elevation, you get off that plane and you go straight up the mountain. You get up there right off the plane. You're coming straight from flat Illinois. It can cause what is called acute mountain sickness because you're going from atmospheric pressure of where we live here in Illinois to atmospheric pressure of at least 8,000 feet up higher. That's a big difference. Causes headaches. And those headaches are not fun. They're not a normal headache either. Shortness of breath, definitely. Nausea, dizziness. I've done all of it. I did that one day, and that was not a smart thing to do. But it can actually lead to edema. Cerebral, so that's in the brain. Edema, collection of fluid, or pulmonary edema, collection of fluid in the lungs. They say you should acclimate to high altitude. But if you're going for a vacation for 3 or 4 days, it's not going to be beneficial. You're not going to have time to truly acclimate. It takes about a week to fully acclimate to those higher altitudes, unfortunately. Or if you decide to go move to those higher altitudes, you'll acclimate and then give a week or so, you'll be fine. But if you take that time to acclimate, your body, those chemoreceptors, they learn to respond to these different pressures of carbon dioxide. When oxygen gets low, you get a decline in oxygen, which stimulates those receptors to, hey, let's breathe more. They learn how to react to that. Your book says it stabilizes in a few days. from personal experience, it takes a little long. It takes more than a few days to get there. It really does take close to a week. Last time I was out in Colorado, I was there 2 days before I went and ran a race up and over a mountain that went up to 12,000 feet. You don't I was there 2 days before, and I still had every symptom of mountain sickness about halfway through the race. So it really does take more than a few days. I wasn't the only one. My friends I went with all experienced it. So when you're at those high altitudes, your hemoglobin's not as saturated, so you're not getting as much oxygen attached to that hemoglobin as you are at sea level. But what happens, because we don't have enough blood oxygen level, our kidneys will produce erythropoietin. Erythropoietin, remember back to the first chapter 8 weeks ago, actually stimulates more red blood cells to be produced and be released out into the bloodstream. That's why a lot of elite runners live at high altitudes and then they come down and run races at sea level. They have a lot more oxygen in their blood because they have a lot more red blood cells than somebody at sea level. It's a trick that can be used to help athletes, Olympic athletes, a lot of Olympic athletes, Olympic runners live at high altitudes just so they can have those extra red blood cells that help them run races. There's also what's known as blood doping. You take out those red blood cells, store them, inject them back in your system before a race. I think we talked about this back in the blood chapter. But that way they have extra red blood cells to pick up more oxygen for when they're running or competing in whatever activity. A lot of cyclists do it too. Lung diseases. COPD. COPD, or chronic obstructive pulmonary disease. You have chronic emphysema and chronic bronchitis together. They have a hard time forcing air out of their lungs. Most of them have a history of smoking. They have dyspnea. It's known as air hunger. Feel like they can't get enough air in whatever they're doing. They usually have a lot of infections in their lungs. They can develop hypoventilation, have respiratory acidosis and hypoxemia because of this hypoventilation. Emphysema. I showed pictures of emphysema before last week, but their alveoli get destructed. So instead of those nice small hundreds of alveoli, they have larger alveoli, so there's not as much surface area around. And because of that, they have decreased lung elasticity. They use more of those accessory muscles for breathing, which involve some of the muscles in your neck to help lift the rib cage, lift the top part of that rib cage up. They end up with exhaustion. They're using 10 to 15% more of their energy just to breathe. They end up with an air trapped in their lungs. So their lungs are filled more than a normal person's would be. So their diaphragm is always, because if their lungs are filled more, the diaphragm is flatter. Because when you breathe in, your diaphragm flattens out. So they kind of look like they have some kind of barrel chest. So they can't breathe as efficiently. They're pulmonary capillaries. So those capillaries that feed into all those alveoli tend to be damaged. People with emphysema usually have an enlarged right ventricle. That right ventricle pumps to the lungs. So that ventricle is enlarged to try to get more blood there. But then when the blood gets there, those pulmonary capillaries just aren't efficient in what they're supposed to be doing. Emphysema can be hereditary. In somebody who has the hereditary emphysema, they have alpha-1 antitrypsin deficiency. So that's something that can actually be tested for in people who have emphysema to find out whether it is an inherited disease or whether it's something else causing it. Chronic bronchitis. Chronic bronchitis could be because of some kind of inhaled irritants. Sometimes you breathe something in constantly and it can cause excessive mucus production. That lower respiratory passageway gets inflamed and it eventually becomes fibrosed, so it's scar tissue. We end up with obstructed airways. If our airways are obstructed, we're not getting air down to those alveoli, which means gas exchange isn't happening. Chronic bronchitis opens people up for constant pulmonary infections. They're constantly getting sick with something. Smoking. Smoking causes a lot of respiratory problems. But environmental pollutants, depending on where people live, what they're exposed to in the air, can cause a lot of breathing and respiratory problems as well. So how do we treat COPD? There's two different kinds of COPD patients. We have what are called pink puffers. These are thin people. They burn a lot of energy breathing. Their oxygen and carbon dioxide levels are pretty normal. And their skin color is normal. Blue bloaters. Those people are usually stocky, they're bigger. Blue because they have cyanosis. Cyanosis means blue. As they are hypoxic. They'll be given some kind of bronchodilator, so some kind of inhaler, maybe some corticosteroids. Eventually, these people may be put on oxygen tanks. They may even do a lung volume reduction surgery. So here's the pathogenesis of COPD. Tobacco smoke, air pollutants, alpha-1 antitrypsin deficiency causes breakdown of elastin, causes bronchial irritations and inflammation, can cause chronic bronchitis and emphysema, can end up with your airways obstructed, dyspnea, infections, hypoventilation, hypoxemia, and respiratory acidosis. Asthma. Sometimes it's classified as COPD, but with asthma, it's usually acute because they have symptom-free periods between their asthma acting up. Usually have really coughing, dyspnea, wheezing. I don't think anybody used the stethoscopes on Tuesday to listen to anybody's breathing, but with somebody with asthma, you can actually hear like a wheezing type sound. It's like a high-pitched sound in somebody's lungs that has asthma from the air traveling through. They'll get chest tightness. Find it's hard to either take a breath in or breathe out. It's one or the other. Sometimes it can be both. You can have inflammation, which can eventually cause bronchospasm. So those airways start to spasm, that smooth muscle in there. They can also be because of an immune response. Some asthma is caused by allergies. So those interleukins, those IgE antibodies, inflammatory cells like those mast cells. Those airways get thick. And as those airways get thicker, the bronchospasms may get worse. Tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. People with tuberculosis, how it affects the respiratory system, they can get a lot of coughing, they can cough up blood. Non-respiratory related, they get fevers, night sweats, weight loss. It usually takes 12 months of antibiotics to get rid of. We're starting to see more antibiotic resistant strains. But tuberculosis does affect the respiratory system. You start coughing up blood, well, it's coming from somewhere in that respiratory tract. Lung cancer. It's the #1 cause of death in the US. 90% of cases come from smoking. We have adenocarcinoma. Anything with carcinoma is cancer. It's usually a type of cancer that will spread easily throughout the body in one way or another. Because it adenocarcinoma comes from the peripheral lung areas, so those outer portions, but it develops from chronicle glands and alveolar cells. Squamous cell carcinoma. I don't know if you guys remember back to Anatomy 1, the integumentary system. Squamous cell carcinoma was talked about. Well, it doesn't just affect the skin. We have squamous cells all over the body. So squamous cell carcinoma can affect the squamous cells in the lungs. So it comes from that bronchial epithelium. Small cell carcinoma. They have lymphocyte-like cells. It comes from those primary bronchi and they will metastasize. When they metastasize, they break off. Some of those cancerous cells break off. They get into the bloodstream. They may get into the lymphatic system and travel somewhere else in the body, attach to something else and start replicating. That's what happens when cells metastasize. So just like any other cancer, early detection. That is the fastest way, the best way to survive it. If the cancer has not metastasized, so it has not traveled somewhere else, they can remove that portion of the lung tissue that is cancerous. But if it has metastasized, that's where they start radiation and chemotherapy. They're always working on new treatments for cancer. So, of course, there's new treatments they continue to work on. Sleep apnea. They temporarily stop breathing while they're sleeping. They don't know they do this. They're tired a lot during the day because they stop breathing at night. But every time they stop breathing, it's going to wake them up. So some people get woken up to 30 times an hour. That's crazy. There's also obstructive sleep apnea. Obstructive, so something must be blocked somewhere. Well, that upper airway collapses. The pharynx may relax during sleep. The pharynx relaxes, it starts to sag back and it causes an obstruction, which causes you to stop breathing and it'll eventually wake you up to breathe. Central sleep apnea. Central has to do with the nervous system. Well, central sleep apnea comes from those respiratory centers and that brainstem. Anyone with sleep apnea is going to have disrupted sleep because every time they stop breathing, it kind of wakes them up to start breathing again. And if you're not getting enough sleep, more susceptible to accidents. You're not getting enough sleep. It causes hypertension, heart disease, stroke, diabetes. That's why it's important to get enough sleep. Obstructive sleep apnea, they have these machines that are called CPAP, continuous positive airway pressure. It keeps those airways open so that you can continue to breathe. So where does our respiratory system come from? It's the last section from this PowerPoint. So our upper respiratory system develops first. We have olfactory placodes. These will kind of invaginate into olfactory pits. This is all present by week 4 of development. We have a laryngeal tracheal bud by week 5. The mucosa of those bronchi and lung alveoli. We already have those by week 8. By week 28 is when a baby can breathe on its own. When babies are in utero, their lungs tend to be filled with fluid because their whole circulatory system doesn't quite work efficiently yet because blood doesn't need to be going to the lungs to get oxygen because oxygen isn't coming from the lungs when you're in amniotic fluid. You're actually exchanging gases in the placenta. So we get that oxygen and that carbon dioxide exchange in the placenta instead of the lungs. That's why the heart, it pumps, but that's where that foraminal valley comes into play because we don't need to be pumping blood for oxygen from one side of the heart to the lungs, back to the heart, out to the body. We pump blood to the placenta instead. So here is what an embryo at 4 weeks looks like. You get that olfactory placode. Then we start to get that laryngeotracheal bud by week 5. It isn't until till birth that the respiratory centers actually become active. As that's when alveoli inflate, when those respiratory centers get activated and the lungs begin to function. After you're born, it takes 2 weeks before the lungs are fully inflated. You ever noticed with a newborn, their breathing rate is pretty quick because their lungs aren't fully inflated yet. A normal respiratory rate for an infant is 40 to 80 breaths a minute, or for a newborn, versus that adult at 12 to 16. Your lungs aren't completely developed until you're a young adult. And your respiratory rate continues to decrease as you get older. I don't know if I've talked with you guys about it, but cystic fibrosis. Cystic fibrosis, they have a very thick mucus. So in their airways, they have that pseudostratified ciliated columnar epithelium. That cilia helps to push the mucus away from the lungs. That mucus is so thick that cilia cannot beat and move the mucus away from the lungs. So mucus starts to accumulate in the lungs. It is one of the most lethal genetic diseases in this country. It leads to bacterial infections because it affects the lungs, but it also affects the pancreatic and reproductive ducts. We have a gene, cystic fibrosis transmembrane conducting regulator, CFTR. So if we have an abnormal CFTR protein, it gets in that endoplasmic reticulum so it never reaches that cell membrane to help with that chloride transport. We use a mucus dissolving drug. You may inhale hypersaline to thin out that mucus. but they're still trying to find ways to fix this problem, really. So what if they're trying to see if they can give normal CFTR genes, what it'll do. Different proteins. It takes over that chlorine channel protein. Trying to free the CFTR protein from that endoplasmic reticulum. There are a lot of different researches that are currently going on to try to help this. So let's look. I put this together. It's got all of the different topics here for the exam next week. I lost my train of thought for a second. So some of this is stuff that you need to know for the practical, like labeling out the different parts of the respiratory system. You have that nasal cavity with the nostrils. You have the nasopharynx at the top, which isn't even labeled. But then we have that oropharynx. That's not really even labeled either, in that oral cavity. And the pharynx, the larynx, that trachea, the carina of that trachea. That is that arc, that bend. Then we have our right and our left lung. That left lung has that cardiac notch. That left lung also has 2 lobes versus the right lobe having 3 lobes, with the diaphragm underneath the lungs and the heart. This goes to label out the nasopharynx, the oropharynx, the laryngopharynx. I think, who was I? Yeah, I need to put this up on. I do need to put this up on Canvas. As well, because I just finished working on this not too long ago. But all the different, what's included in there, we have the pharyngeal tonsils, palatine tonsils, laryngeal tonsils, and the oropharynx, nasopharynx, the larynx, the glottis, the epiglottis, the vestibular fold versus the vocal fold, the trachea, the esophagus, the parts that make up the upper respiratory system versus the lower respiratory system. That upper respiratory system is that nose, nasal cavity, sinuses, all the way down to the pharynx. The lower respiratory system starts at the larynx. What does our nose do? It's an airway to breathe. It helps to moisten and warm the air before it goes down into our lungs. It cleans the air out, so we're not breathing any kind of pathogens down into our lungs. But our nose also helps to create our voice. If you've ever noticed when you have a cold and your nose is congested, how your voice changes versus when you are not congested. Your nose also is what allows you to breathe, because it has those smell. Sorry, it has those olfactory receptors because you can smell with your nose. We have those nasal concha. We have that superior, middle, and inferior nasal concha. And the meatus is the groove underneath each of those. The meatus and those concha help to moisten that air, filter it out, heat it up. And reclaims that moisture and that heat before you breathe out that air. So our vocal folds. We have our true vocal cords, and the vestibular folds are the false vocal cords. We have ligaments that attach to those arytenoid cartilages into the thyroid cartilage that help with the vocal ligaments or vocal folds. And as I said, that left lung has two lobes, superior and inferior, with that cardiac notch. That right lung has a superior, middle, and inferior lobe, which has a horizontal fissure and an oblique fissure. We have a right and left main bronchi that go to lobar bronchi, segmental bronchi, bronchioles, terminal bronchioles, which feed into the alveoli. That transpulmonary pressure is what keeps those air spaces open and keeps those lungs from collapsing. Voice production. Your speech. Your voice is produced as you exhale air, with opening and closing of the glottis. The glottis is the space, that opening behind the epiglottis. The pitch, how high or low, is determined by the length and the tension of those vocal cords. Higher tension, higher pitch. Lower tension, lower pitch. Your loudness. How much air are you trying to force out? Your mouth, your nose, your sinuses. They can change that sound quality. The actual words that come out are formed by the pharynx, the tongue, the soft palate, and your lips. So when you inspire, your rib cage expands, so that whole thoracic cavity gets bigger. Your lungs get stretched as air goes into the lungs. Intrapulmonary pressure drops by 1 millimeter of mercury, so pulmonary pressure is less than atmospheric pressure. Because of these two differences, that's what causes air to flow into the lungs, because our goal is to get pulmonary pressure equal to atmospheric pressure. Quiet expiration, that's a passive process. That's a process where it just kind of happens naturally, because the muscles we use to breathe in will relax. And think about it, if your intercostal muscles start to relax, that causes your thoracic cavity to go down, which causes your lungs to decrease in size, which causes air to go out. So as the volume in your thoracic cavity decreases, that intrapulmonary pressure is going to go up by 1 millimeter of mercury. So yet pulmonary pressure is greater than that atmospheric pressure. So that's another reason why air flows out of the lungs. Because we again want to get that pulmonary and atmospheric pressure equal to each other. Let's go back to the trachea. I tried to put this in somewhat of order, but some of it's a little bit out of order from going from the upper respiratory system and just working its way down. But our trachea has 3 layers. The innermost layer is it ciliated pseudostratified epithelium with those goblet cells that produce that mucus. That submucosa, that's underneath it. Whenever you, I shouldn't say whenever, probably about 95% of the time when you have some sort of epithelium, you're going to have some sort of connective tissue underneath that epithelium. Your trachea, you do. So we have that connective tissue underneath that epithelium. We're also going to have those hyaline cartilage rings. That's what keeps your trachea from collapsing. They're going to hold your trachea in place. Then we have an adventitia. That's that outermost layer of connective tissue. So where does the respiratory zone, so when air exchange really starts to happen, well, those terminal bronchioles feed into respiratory bronchioles, which lead into alveolar ducts, which finally lead into those alveolar sacs. That's where those respiratory zones begin, and they travel in that direction. Alveolar sacs have alveoli. We have about 3 million alveoli in our lungs, and that is where gas exchange occurs. So those changes in respiratory rate and depth affect your blood pH. So if you're going to breathe slow and shallow, it's going to increase carbon dioxide. pH will drop. Rapid deep breathing will decrease carbon dioxide and pH will rise. Smoking inhibits and will eventually destroy the cilia. And that is what causes that smoker's cough. So, because that cilia, there's no cilia working, the cilia is not there, so mucus accumulates. And as mucus accumulates, you got to cough it out. But if somebody stops smoking, that cilia starts working within a few weeks. Doesn't take much. It's pretty quick to recoup itself. And then that smoker's cough starts to go away because that cilia is there to then beat the mucus away from the lungs again. Tracheal obstruction is life-threatening. That's where that Heimlich maneuver comes into play. If something is stuck, that Heimlich maneuver will help to push whatever is obstructing out of the lungs. Could be a piece of food, could be anything swallowed that attempting to swallow that shouldn't be. What about that intrapulmonary pressure or pressure in the alveoli or intraalveolar pressure? Well, as you breathe in and you breathe out, it's going to change. But it's always going to equalize. No matter if we're breathing in or we're breathing out, it's eventually going to equal out. It's going to equalize to that atmospheric pressure. As I showed a few slides before with inspiration and expiration, how everything equals out, no matter whether you're breathing in or you're breathing out. Surfactant. Surfactant will reduce surface tension. It prevents those alveoli from collapsing, and they are produced by type 2 alveolar cells. Oxygen, of course, it's carried in the blood. Majority of it is bound to hemoglobin and red blood cells, but there is some of it that does get dissolved into that plasma. So how much oxygen we carry in our blood is going to depend on oxygen's binding and releasing ability with that hemoglobin. So that hemoglobin saturation depends on how much oxygen is attached. And that's what gives us that oxygen hemoglobin dissociation curve. There's different things that can change hemoglobin structure, such as an increase in temperature or a decrease in temperature. Hydrogen, carbon dioxide, and BPG, they can all modify that structure. This really is out of order. So as we, sorry, inspiration, gases goes into the lungs, that diaphragm descends, rib cage rises. Expiration, gases exit the lungs, diaphragm rises back up, your rib cage is going to lower. Our airway resistance, or that friction. How easily does that air get into that alveoli? So our air resistance depends on the diameter of the airways. The branching, they're going to get smaller and smaller and smaller as they go down all the way to those alveoli. If we have resistance, it's going to happen in those medium-sized bronchi. And by the time they get to those terminal bronchioles, it's pretty much gone. Hypoxia, we're not getting enough oxygen to our tissues. Could be because of low levels of oxygen in the air. Cells can't use the oxygen, not enough red blood cells, too little hemoglobin. Hyperventilation, increased depth and rate of breathing. Could be because of anxiety attacks. Emphysema, permanent enlargement of the alveoli. Those alveoli get destructed. So your lungs aren't they don't have the elasticity anymore. Rhinitis is inflammation of that nasal mucosa, while pleurisy would be inflammation of the pleura, and a lot of times it comes from pneumonia. So what affects our breathing rate here? Raising carbon dioxide levels, our pressure of oxygen in our blood only affects the breathing rate if it's significant loss of oxygen. And it is again monitored by those chemoreceptors. The pH can also affect breathing rates. We have a blood-air barrier, which is those capillary walls and those alveoli walls. And their basement membranes. That is what allows for simple diffusion of gases. Our alveoli, they have that simple squamous epithelium, which is a type 1 alveolar cell. And then we have the type 2 alveolar cells, which create surfactant. So that tidal volume, how much air you breathe in and out under resting conditions. So you're just, what you're breathing right now, just sitting. Inspiratory reserve is the amount of air that you can breathe in forcefully. Expiratory reserve, the amount of air you can forcefully exhale. residual volume, there's always going to be some volume of air always in the lungs after you breathe out. That total capacity is how much air your lungs can contain. Vital capacity is the amount of air that can be breathed out after a maximal inspiratory effort. That inspiratory capacity is the maximum amount of air that you can breathe in. Functional residual capacity is the amount of air remaining in the lungs after a normal tidal volume expiration. So one of those is respiratory volumes, the other one is respiratory capacities. In our brain, you have those pontine respiratory centers, those ventral respiratory centers, dorsal respiratory groups, and then that phrenic nerve that comes down to feed the diaphragm. Technically, the intercostal nerves that come out from the spinal cord is what feeds those intercostal muscles, if you want to be technical about it, but that's not going to be asked. Carbon dioxide is transported in the blood, either by dissolved in plasma, bound to hemoglobin, or as bicarbonate ions. Our lungs are innervated by sympathetic and parasympathetic motor fibers and visceral sensory fibers. Nerves will actually enter. We have a pulmonary plexus of nerves on that lung root specifically. Then Boyle's law. Gases always fill whatever container they are in. So I think I drew this out last week. So if we have a container, a sealed off container with some gas in it, we take a bigger container, the same amount of gas. Boyle's law says it the other way. So I have this bigger container. If the size of the container is reduced, the pressure will increase. If I go from a smaller container to a bigger container, that pressure is going to decrease because you have the same amount of gas. There's just more space. If we're going from smaller to a bigger, there's more space for that gas to spread out. So it's going to decrease because there's more space to fill still. Versus if we go from that bigger to that smaller, it's going to increase because we're going from a bigger container to a smaller container. So there's less space in there for that air or that gas or whatever. So pressure varies inversely with volume. Something Boyle's law, something to keep in mind for the practical on Tuesday as well. Because Boyle's law will come into play with one of the questions. If we're going from a smaller container to a bigger container, pressure will decrease. Think of your lungs, resting size. You breathe in. You're starting at a resting rate. Everything is condensed down. You breathe in, the space increases. So if that container, your lungs, increases, pressure is going to go down until more air comes in, when it'll equal out. But then once you breathe out, think of the residual air that's in your lungs when you're doing normal tidal volume. Breathing in, breathing out. There's always that reserve of air always in your lungs. So that reserve of air, as you breathe in, there's more space, so that pressure goes down. That reserve air, when you breathe out, there's less space, so that pressure goes up. That'll help with the practical and the written exam next week. I will get this posted on Canvas here in a minute for you. You're welcome. Is anyone have any questions? If not, I will put this under the module for the respiratory system specifically. Structure of the exam. It'll be multiple choice. There will be some matching. Let me double check. There might be a couple. Wait, wrong test. There it is. Multiple or true false. Let me. Yeah, there's matching. There's 1, 2, 3, 4, 5, 6. 6 true false. There's one matching section. Yeah, 6 true false. The rest of them are multiple choice. There are, scroll 50 questions on the test. So if there any other questions, oh no, sorry, there's 2 matching. Found another one, sorry. As I'm scrolling. So yes, you're welcome. If there's no other questions, I will get this respiratory review PowerPoint posted here in the next couple of minutes. I gotta find it in my system and then download it and upload it. And you guys are free to go. Have a wonderful weekend. And I will see everybody on Tuesday.
Thank you.
You're welcome. Good night.